Good evening, all, to the 102nd session of the Weekly Huddle. I'm your host, Anoop Agrawal, and joining me today is my colleague and co host, Praneeth Pulamuri. We both are cardiologists working at Care Hospital, Banjara Hills. Today, we are going to talk about a clinical case, but particularly, we will try to focus our discussion on the newer molecule, which is about to hit the Indian market. And this is something which we think is going to hold promise, so we might well get well versed with this. And that will be the Bempedoic acid, which was US FDA approved, I believe, late last year for lipid management. So this case is as follows. It's a 46-year-old female. She was admitted 2 months back with ST elevation myocardial infarction, for which she underwent primary PCI. She was discharged in a very stable condition with routine medications on board. She has a past history of diabetes. She had been on proper medication because of that. And I would say it was reasonably controlled, not excellent, but reasonably controlled. She wasn't quite regular with her follow-ups. Today's visit is her second follow-up after the recent admission for acute MI. She was seen once after 2 weeks of discharge, and now this is her second visit, which is close to 2 months since her index admission. During this visit, she has finished her 3 weeks cardiac rehab program. She was advised to undergo for 5-6 weeks. She did for 3 weeks, and after that, she said, I was feeling fine, so I stopped doing it. She has resumed most of her daily activities. She is a housewife. She does not need to particularly get out of her house for her work or whatnot. And daily activity work that she has resumed, she does not have any angina or any heart failure. Her sugars are now reasonably controlled. She has been started on SGLT2 inhibitor. She's currently still on insulin, although that requirement is not much. So the idea here is that the insulin requirement hopefully will go away later on, and she will be only on oral hypoglycemic agents. She's on all of the routine cardiac medication that you would expect a patient to be on after acute MI. In this present visit, her physical examination is unremarkable. She did undergo a panel of investigations, which typically I do at the second follow-up of an acute MI, which included hemogram. It included renal profile, lipid profile, all those kind of things, and ECG echocardiogram. All of her reports were pretty unremarkable, and if anybody needs any particular detail, I will supply it with that. Right now, I am refraining from telling you individual details because we want to focus on her lipid profile. Her LDL, which is 2 months after her MI, is 96, and she is maintained on rosuvastatin 20 milligrams since her discharge. She's on other medications, including beta blockers, which I have no intention of stopping right now. Her total cholesterol is close to 210, and HDL is about 41.5, 42, something like that, and triglycerides are 86. So I'm trying to focus on this LDL 96. This is what draws my attention, because I, in my practice, want to drive the LDL as low as possible. So to me, this LDL of 96 is still suboptimal, but we will engage in discussion with my attendees about what they think. So the topic for today's discussion is managing dyslipidemia beyond statins in these patients who are at high risk for recurrent cardiovascular event. That what should be our LDL targets for secondary ASCVD prevention? In these particular subsets, should we increase the statin dose where she's already on 20 milligrams of rosuvastatin, or should we add the additional drug? And if we go down the route of adding additional drug, then should that drug be ezetimibe, which is US FDA approved for more than a decade now, or PCSK9 inhibitor, which again had been in market for quite some time, although it is injectable and costly, versus we do other drugs like niacin or fibrates or omega-3s or whatnot, and what role this drug bempedoic acid can play in these patient subset, understanding that this is not uncommon scenario for our clinical practice. And since this medication is bound to hit the markets and we will be quite significantly exposed to this with the initial drug showing, with the initial data showing a promising result. Where does bempedoic acid play a role in such patient subset? So with this introduction, I will ask Praneeth to give his opinion, and then I will ask the rest of my attendees to share their opinion as well. Praneeth, you can go ahead.
Yeah, good evening, everyone. So this patient, as you said, patient has an acute coronary syndrome and ASCVD event. And for so-called secondary prevention of her ASCVD events, we need to give her high-intensity statins. Irrespective of the cholesterol level, there should be an expected or targeted LDL reduction by close to 50% because that led to an ACS event. So even if this patient were having LDL cholesterol of 70 for that matter, she still deserves moderate to high intensity statin because that LDL, she will belong to a high risk subset. Now, 2 months post ACS, she is having an LDL of 91. So we do not have a baseline baseline LDL cholesterol level, and the drop in LDL cholesterol in 2 months, we normally at least repeat in 3 months, if not 6 months. So I presume probably her LDL maybe was around 120-ish, and it dropped from 120 to 96. So the guidelines say that LDL target should be less than 55. Now, how do we achieve this target? The first important drug is to give maximally tolerated statins. Rosuvastatin 40 milligrams is the high intensity statin. So for this patient, I would try to increase the dose of rosuvastatin from 20 to 40 and see for the response. If you can tolerate rosuvastatin 40 milligrams with all the counseling, and if she is okay, and if we are able to reduce LDL cholesterol levels to less than 55, I'm okay. Most of the time, be it because of patient factors, psychological factors, or whatever, most of the times there is a so there's a challenge in increasing the dose of statin. In that case, if the so-called statin intolerance, if it is presumed to be there, though most of the time it is not true statin intolerance, but for practical purposes, if we presume that she is not able to tolerate statin intolerance, then we look for alternatives. I would start this patient on estimate 10 milligrams, and which can reduce the LDL cholesterol level by around 10%, or maybe another 10 milligrams deciliter drop can be expected. So I would first start this patient on estimate. If the patient does not tolerate a combination of maximally tolerated statin and estimate, then the alternative options would be to propose them PCSK9 inhibitors. The challenge being it is injectable and it is expensive. The point of discussion for today, bempedoic acid, is said to be reducing LDL cholesterol levels by close to 15 to 20%, in addition to statins in various trials that has been tested. So if a patient is not in a position to afford PCSK9, then I would prescribe this patient bempedoic acid. I would be I'm not very confident at this point of time, but probably over a period of time with more data coming, that is the that I believe is the way forward, where patients who are not able to tolerate maximal doses, or who are not able to reach their LDL targets despite maximally tolerated statins, then they should be added on bempedoic acid. Of course, other lifestyle measures you already insist on, and I think that is the discussion for today, and this is my opinion. Probably I would be interested to listen to what others have to say in this molecule.
So Praneeth, I have a question for you. When I was getting my training, for me, a high dose statin was rosuvastatin 20 and atorvastatin 40, 40 or 80, you can say. When did this rosuvastatin 40 milligram became the high dose and 20 milligram became the moderate dose?
So this is that gray area where you say that high intensity is being 20 to 40 milligrams, At least the maximal tested or prescribed dose is 80 milligrams of atorvastatin and 40 milligrams of rosuvastatin. So I would try to increase it as far as I can before going to the second drug. So that is the thought process of giving that comment.
So the question that always comes when we talk about going rosuvastatin from 20 to 40 is the incremental benefit in lipid reduction versus the incremental risk of hepatotoxicity or muscular toxicity. Do you have any idea? Is there any objective way that we can look into this?
I have no idea on this thing, Anoop.
And then let's say going forward, you have a situation where you have all the three drugs readily available, that is ezetimibe, PCSK9 inhibitors, and bempedoic acid in the current form as it is, which is tablets, injectables, pricing, and all those kind of things. Would you still put bempedoic acid behind PCSK9 inhibitor?
No, I would give them PCSK9 inhibitors.
Sorry, you would give PCSK9 inhibitor
Yes.
over bempedoic acid?
Yes.
Okay. And why is that?
Because of the established safety profile of PCSK9 inhibitors and the established efficacy of PCSK9 inhibitors, where you expect definitely a 50% or more reduction in LDL cholesterol levels. Bempedoic acid, right now, though the data is promising, we still don't have a CVOT trial to establish its safety. There is also a kind of a slight increase in the risk of gout, and equally the possible side effects of muscle symptoms, which are common with statins, are also expected with bempedoic acid. PCSK9 being a monoclonal antibody is relatively safe. The only caveat being it is injectable, but it is safe and it is effective. So I would choose PCSK9 inhibitors over bempedoic acid.
All right, Praneeth, I will move on with my discussion. I will ask Vijay Reddy sir. Sir, if you can hear me, could you please share your thought about this particular patient in terms of how to manage lipid reduction therapy in this particular patient? Are you happy with 96 or you want to go aggressive and your drug of choice? Vijay sir, I don't think I'm able to hear you.
Good evening to everybody. Here, the scenario is a 46-year-old. Now, hello? Able to
Yeah,
hear me?
we can hear you, sir.
Hello?
It's just a little faint. We can hear you. It is just a little faint.
Okay. This scenario is a 46-year-old female with STEMI, post-PCI, diabetic with rosuvastatin 20 milligrams of and LDL of 96. This is the scenario. So I think the target goal of LDL in this patient is less than 55. So rosuvastatin, I will switch over to 40 milligrams or atorvastatin 80 milligrams. If still the patient does not reaches the target of less than 55, I will add ezetimibe. Even with that also, if the patient does not achieve the target levels of LDL, my line is divided. If the patient is financially stable and he can afford, I will go for PCSK9. And if the patient cannot afford, I will go with bempedoic acid. Because bempedoic acid has got some advantages when compared to the statin-induced myopathies. They are not seen with bempedoic acid, though uric acid may be increased and gout is one of the contraindication for bempedoic acid. I will go with this bempedoic acid 180 milligrams. That is so first is high dose of statin, ezetimibe, patient financial status. If it is good, PCSK9, not good, bempedoic acid. This is my strategy for this patient.
Sir, I have few follow-up questions. One question which I asked Praneeth, I will ask you again. The same thing, rosuvastatin going from 20 to 40, the incremental benefit of LDL reduction versus incremental risk of hepatotoxicity and myotoxicity.
myotoxicity of statins is seen in patients who are having mixed edema, mostly, and there is slight elevation of this CPK rhabdomyolysis with frank renal failure is very unusual, though it is, I have seen some few cases, but very unusual. But the recommendation is high intensity means 40 milligrams of Rosua or 80 of Atorva.
My second question to you, sir, is let us assume this patient do not have any major financial constraint, but at the same time, she is not a millionaire. She can afford costly medication. The question is for how long? So let's say if this patient says I'm okay for PCSK9 inhibitor, how long would you be aggressive with this drug and when will you be willing to back off, understanding
At
that a
least
lifelong...
at
Right.
least for 6 months, PCSK9 inhibitors.
Right. The rationale of me asking this question is, which you already know quite well, that the lifelong management of hyperlipidemia with PCSK9 inhibitor, somebody may be financially okay now. After 3-4 years of PCSK9 inhibitor, they may not be financially okay anymore.
No, that's true. So if the patient is not cannot be affordable, we can switch over to Bempedoic acid. There is no alternative.
But 6 months you think is quite reasonable for you to put them on
Yes.
the drug and then back off after that?
Yes. 6 months is reasonably good time.
Perfect. Thank you so much, sir. I will move on. I will invite Shankar sir for his opinion about this particular patient and how would he manage the lipid profile, knowing that we are going to probably get drowned with newer so-called branding of this bempedoic acid in our clinic. Shankar sir, how would you take up this case?
Good evening to all. Now already discussed regarding the management of lipids in this case. So this comes under a very high risk group case, because since there is established atherosclerotic cardiovascular disease is there in the form of coronary artery disease, the recent MI is there. So very high risk means the target level, according to the ESC guidelines, it is less than 55. And even according to our Lipid Association of India, LI, it will be less than 50 also. And optionally, it can be even, it will be better, even if it is reduced to 30 milligrams per deciliter. So here already the patient is on rosuvastatin 96 milligram per deciliter. So we have to reduce it to less than 50. So the maximally tolerated statin dosage we have to resort to. So in this case, high intensity statin, so up to 40 milligrams of rosuvastatin can be given. So in spite of giving 40 milligrams of Rosua, after 4 to 6 weeks, we repeat lipid profile. And if we don't reach the target, then we can add ezetimibe, that is a 10 milligrams the standard dose. Then even after Rosua, maximally tolerated dose and ezetimibe, if we don't reach the target level of LDL, then we have got two options, as already discussed, the PCSK9 and Bempedoic acid, which is recently launched into the Indian market, available as a Bemdoc, 180 milligram tablet. So the PCSK9 is really, it has got a lot of literature is there. Then, but only thing is it is a high cost, more than 40,000 per month, the treatment. And so it is injectable. So we have to give every 2 weeks subcutaneously 140 milligrams. So that is regarding the parenteral and as well as the high cost. So recently, this Bempedoic acid, which has been launched into the Indian market, is it takes over the function of this PCSK9 I believe, because if you go to the go through the literature, because though we have got a scanty experience with this molecule, but this bempedoic acid, except as Dr. Vijay Kumar already alluded to, so it increases the serum uric acid levels and it causes gout flares. That's why it should we should be cautious about using this molecule in gout patients, or where there is patients of hyperuricemia also. And see, if we combine this ezetimibe and bempedoic acid, we can reduce this LDL cholesterol more than 38% together. So even in abroad, the combination is also available. So here only Bemdac it is available. So I prefer to give bempedoic acid. In this case, if LDL cholesterol target levels are not achieved with the Roswa maximally tolerated dose and as well as the ezetimibe combination, then we switch over to the bempedoic acid, and we'll see other apart from lifestyle changes like a diet and exercise. Thank you.
Sir, my question to you, sir, is if you have to give us a rough number, how many of your patients have ever been tried on PCSK9 inhibitor? Give us an idea.
I don't have any experience regarding this PCSK9. I leave it to higher. I refer those cases to higher centers only, because this is patient cannot afford in our area, and at the same time, even if I don't have any experience regarding the PCSK9. A lot of literature is there, and how to administer. This is subcutaneous. The pre-filled pen is there. So that the Bempedoic also I have not yet started. This is just to launch into the market only on 13th May or 14th May.
So do you know what is the cost at which bempedoic acid is launched in India?
Exactly, I don't know, but it is $14 per day. 180 milligram tablet orally. It costs $14 in US. But when it comes to India, it will be very less, I think.
Right. So just to let you guys know, early on when we were doing data analysis of PCSK9 inhibitor, I was trying to look at the number needed to treat and the cost associated with that. So, you know, like I do TAVR, we all know TAVR is a very costly therapy, and we always look at the cost implication whenever we offer TAVR to our patients. For those of you who don't know TAVR, the average cost comes somewhere around 20 to 30 lakh rupees, depending upon what kind of valve we are using and all those things. This definitely is one of the most costly procedure that we do in our routine practice. When I was looking at the number needed to treat to save one life using PCSK9 inhibitor and the cost associated with that, in India, that is upwards of 1 crore. That is much higher than what you need TAVR to save one life. In terms of preventing so-called cardiovascular mortality. So while the drug itself at the face of it is costly, when you actually look at in the spectrum of how much money you need to spend to save one life using PCSK9 inhibitor, you realize that this therapy is actually costlier than TAVR. And TAVR, as I'm saying, is one of the costliest therapy in the cardiovascular space. PCSK9 inhibitor is so costly that early on UK NHS did not even allow PCSK9 inhibitor at that cost structure to enter into the UK market. PCSK9 inhibitor is so costly that Canada had to negotiate of 1/4 price that of US for it to even allow entering into Canada, and that was also a big hassle at that time. Just to give you an idea and the perspective of what we are talking when we are talking about PCSK9 inhibitor in that subset. Now, I don't know at what cost bempedoic acid is going to be launched in India, but definitely while PCSK9 inhibitor is an excellent drug, the reason why, Dr. Shankar, you don't have a patient whom you have prescribed, or we as cardiologists also have very, very handful patients whom we have prescribed, primarily for this reason, that the cost is not only high, it's actually significantly prohibitive to even those patients who can't be considered poor by any means. Even an average middle class or above middle class person affording PCSK9 inhibitor for a long term is going to be very difficult. Now, what Vijay sir said is that we give it for first 6 months in the highest risk period and then we back off. That could be a reasonable strategy, provided we know what we are doing in that regard. So whether bempedoic acid is going to eat up some of that market or not, I don't know. Definitely, there are a lot of patients who are in need of these kind of drugs because they are either intolerant to statin or statin is not doing an enough job. Like in this particular patient, if I have to just put some numbers, a 20 milligrams of rosuvastatin is expected to reduce LDL level by anywhere between 30 to 40%. So if we think that in 6 weeks or 2 months, 20 milligrams of rosuvastatin has done enough job to bring the LDL to 96, making from 20 to 40 milligrams may add another 5 to 10%. And adding ezetimibe is going to add another 10 to 15%. So even if we take all of that into account, I don't expect the LDL to be predictably go below 65 or 70, let alone going below 50 or 55, which some of you mentioned that should be your target, which I agree it's a very aggressive target. Nonetheless, it is approved by the guidelines, or it is endorsed by the guidelines to get the target level down to 50 or 55. I do not think that adding that increasing rosuvastatin from 20 to 40 and then adding ezetimibe in this particular patient with the given knowledge that we have is going to reduce it to below 50. So we have an option of either adding PCSK9 inhibitor to start with, or give this person a triple drug therapy, which is high dose statin plus ezetimibe plus a bempedoic acid. And you hope that a combination of all of this can add another 30 to 40% reduction in the LDL than what we are currently seeing. I hope I'm making some sense in terms of why I rationalize this kind of discussion. Because if we have to escalate drugs every 2 months or every 6 weeks, then it will be 6 months after her index event where we will realize that 2 or 3 of our drugs are not working and that we need to escalate. So there won't be a point adding this patient with PCSK9 inhibitor 6 months after her event when the initial phase is already over. So we need to be far more aggressive in treating this at the current time as compared to traditionally what we do with hyperlipidemia management, where we give a drug, wait for 2-3 months, again check cholesterol, and again titrate these drugs. In these patient subset, we have to be far more aggressive at the very beginning of it. And whether adding ezetimibe alone or increasing rosuvastatin from 20 to 40 alone will reach that target, I don't know. Praneeth did mention about the reduction in LDL by more than 50%. So Praneeth, in my defense, I do not check cholesterol level when they are admitted in the hospital for acute MI, because acute MI being an inflammatory state, it does give a falsely high cholesterol levels. So I actually check cholesterol level either in a stable situation before an event has to occur. If an event occurs, I typically check their cholesterol after 6 to 8 weeks of the therapy. With my strategy, I do not have a baseline to compare where I can take a 50% reduction from there. I do not have a baseline. I do not take a baseline in patient who get admitted with acute MI. Whether that's a good practice or not, I don't know. But this is typically what I do. If I'm seeing a patient for the first time in an acute ACS episode, I do not check their cholesterol level at that time. I actually wait for at least 6 weeks before I check their first level. So Vijay sir writes that the cost of bempedoic acid is 25 to 30 rupees as per different brand. So, with the 25-30 rupees, we are talking about close to 900 to 1,000 rupees per month cost versus, and then ezetimibe is going to add another 1,000 rupees. So we are talking about 2,000 rupees per month as compared to a PCSK9, which is going to cost somewhere between, I would say, maybe 25-30,000 rupees, if I'm not mistaken, per month. So the cost difference is absolutely astronomical. So that was my take on this kind of patient subset. What I did was I increased this patient's rosuvastatin from 20 to 40, and I did add ezetimibe 10 milligrams in the same setting. I did not add PCSK9 inhibitor because of cost implications, and bempedoic acid right now was not available to me when I saw this patient in the clinic. So I did not start on bempedoic acid, but I was very keen that if that drug indeed was available in the market, I would have prescribed it to this patient. Whether starting all these drugs at the same time is the right thing to do or not, I don't know. If somebody has their opinion, I would ask them to share their opinion about this. Okay, that was my thought. Any other leading points that anybody has? Maybe we can discuss that. One of the question that was asked is, what is statin tolerance? This was asked by Dr. Bipin. Praneeth, you want to mention what is statin tolerance or statin intolerance? Whatever, how do you judge that? How do you assess? First the definition, and secondly, how do you assess that?
So definition, I do not have the exact wording, but the point is that you have to, patient develops symptoms of muscle involvement in the form of cramps, pains, and some elevation of enzymes as well. And that has to be tested by at least 2 statins and with the lowest tolerable doses. So if you have tested with 2 statin drugs and you have started with the lowest dose possible, and even then if the patient developed any of these muscle symptoms, then it is said to be having statin intolerance. The severity is also graded from mild to severe, where mild is only some muscle aches kind of a thing, to severe where there is obvious evidence of rhabdomyolysis in the form of enzymatic elevation and reversal with stoppage of the statin therapy. There is a definition of the so-called statin intolerance that I know. And regarding, I think that probably answers the question, Anoop. Did you ask anything?
So that is when the lowest dose is there and whatnot, but how do you assess tolerance when you are going from 20 to 40 for rosuvastatin?
So checking the tolerance, you again watch for the same symptoms, like you increase the dosage and look at the clinical picture of the patient and ask the patient to report if she has any new symptoms, particularly muscle cramps or muscle pains is something that you look into. So if the patient comes off any cramps or any muscle pains, then you presume you try to have a temporal association with the change in dose to the onset of these symptoms, and then you try to correlate. And sometimes for confirmation, you ask for the CPK enzymes for confirmation.
And what do you do when you have statin intolerance with enzyme negative? Do you back off on the drug, or you can do something to increase the tolerance?
As per the literature, most of the statin intolerance is actually overemphasized. It is the incidence is actually less than 1%, or 1 in 10,000 patients can have the so-called statin intolerance. So majority are not true intolerance. So most of the patients, I do tend to counsel them about these aches and pains. Could not be because of it. It could be mostly psychological. I would ask them to continue them if it is mild and tolerable. telling them about the risk benefit analysis of the benefit offered being much higher than the risk associated or the pain that you are going through, and try to get them get their confidence. But if they do not, then I would try to reduce to the previous dose which they were comfortable with, and even if that is not tolerable, then I would try to stop it.
Thank you so much, Praneeth. The floor is open for discussion. If anybody has got any questions, comments, or anything, you can you please feel free to share. You can either put it up in the chat box as a question, or you can unmute yourself to speak out your thoughts. Shankar sir, you have anything to add?
Regarding bempedoic acid, in addition to the diet, ezetimibe and maximally tolerated dose of Rosuva or Etorva, then another indication for this bempedoic acid is in the familial hypercholesterolemia, especially in the heterozygous, not homozygous. So another indication also for the bempedoic acid is the familial hypercholesterolemia. If targets are not reached with the statin, then we can add this bempedoic acid in the FH. And another one is, so on the top of statins, if bempedoic acid alone, it reduces 17 to 20% of LDL cholesterol. And bempedoic acid along with the ezetimibe combination, it reduces more than 38% LDL cholesterol reduction. And one more side effect with the bempedoic acid is, especially we should be cautious regarding patients with the disorders of tendons. So tenosynovitis or Achilles tendinitis, or some tendon disorders. So there we should be very careful, because the tendon rupture is one of the complications of this bempedoic acid. So we should take history of any tendon disorders are there or not. And we should be cautious when we give bempedoic acid along with the corticosteroids or fluoroquinolones like ofloxacin, moxifloxacin, floxacins. So there, these tendon ruptures are more prone. So this has to be kept in mind, apart from the hyperuricemia and the gout flares. And one more thing, when we combine with the simvastatin, we are not using nowadays simvastatin or pravastatin. The dose should not be increased more than 20 milligrams of simvastatin and 40 milligrams of pravastatin when we use bempedoic acid. Otherwise, there will be more toxicity will be there. But these two molecules we rarely use. So whenever we come across usage of this simvastatin or pravastatin, then the dose should be 20 and 40 milligrams respectively. Thank you.
Sir, just for the completion's sake, could you please enlighten about homozygous and heterozygous familial hypercholesterolemia? The reason why I ask this question is because I'm sure most of us are not checking for genetic analysis. So as a physician or as a cardiologist, when should I suspect heterozygous or homozygous hypercholesterolemia in my patient?
This comes under genetic studies only, but I too don't know exactly. But in the literature, it is specially mentioned that heterozygous only. I too, if anybody enlightens me, I'll be very happy.
Thank you so much, sir. If anybody can share their thoughts about in the clinical practice, what should prompt us to think about familial hypercholesterolemia in this kind of patient subset, that will be a good thing to discuss. Anybody else has got any other thoughts, questions, or comments about today's topic? And while you guys gather, I'll just put my narrative as well. I'm just buying time for any one of you to gather your thought, to ask questions or comments. So Shankar sir mentioned in a flyby, I'll just reiterate that. The fixed dose combination of bempedoic acid and ezetimibe is already approved, I believe, by the US FDA, but it definitely is approved by a lot of authorities, and it is currently available outside of India. My guess is, as the bempedoic acid becomes more common molecule in India, we are more likely to see a fixed dose combination of 180 milligrams of bempedoic acid and 10 milligrams of ezetimibe. For some reason, ezetimibe did not catch up the kind of attention that that it probably should have. I remember during my training days, the molecule called Vytorin was tested in the trials, which was a combination of atorvastatin and ezetimibe. The only criticism of those trials was that the dose of atorvastatin was not at its maximal dose. But regardless, that combination was approved. So Vytorin was available in the United States, and we were quite comfortable using Vytorin in US. In India, unfortunately, most of the ezetimibe combination that comes with statin, they are clubbed with low dose statin. So we have got ezetimibe combination with 10 milligrams of atorvastatin on 20 milligrams of atorvastatin. And as we all have discussed, that if a patient is on atorvastatin 10 or 20 milligrams, and if we need an additional therapy, we will probably increase the statin dose first before we add ezetimibe. So to me, ezetimibe combination with 10 milligrams of atorvastatin does not make sense. But unfortunately, that is what is available. I don't think there is any fixed dose combination with 40 or 80 milligrams of atorvastatin or with 20 or 40 milligrams of rosuvastatin. I don't think that combination exists in India. But going forward, I'm guessing that a combination of bempedoic acid plus ezetimibe may come into the market. And when that is available, then I think in our escalation matrix for statin therapy, a patient who is either statin intolerant or didn't reach the target with maximal dose statin, they can be started on that fixed dose combination. And Vijay sir just wrote that lipase E is available 40 and 10. So I'm guessing, sir, that 40 is atorvastatin. So that lipase E is 40 of atorvastatin and 10 of ezetimibe. That is still reasonable. Most of us would still be giving 40 milligrams of extra atorvastatin to this patient. So the patient will be taking 2 tablets for sure. I wish that there was a 80-10 of atorva or a 20-10 or 40-10 of rosuvastatin, such combination available, which would have been the standard of practice as a general. So that was about the drug. Any other questions or comments?
And one more thing is, the advantage of this bempedoic acid is, see, the statins, they increase the risk of diabetes. But whereas this bempedoic acid, it decreases the risk of diabetes. This is quite a useful thing to be noted down. It reduces the risk of diabetes, and it reduces the high sensitive C-reactive protein also, along with the LDL cholesterol. The many advantages are there, bempedoic acid, except only hyperuricemia and little tendon problems. But probably this will click in the market where we resort to the target goals of LDL cholesterol. Definitely this helps a lot. Thank you.
Shankar sir, one question I have for you. We discussed all of this from a data-centric viewpoint, from whatever the guidelines have been mentioned. You did mention about Indian guidelines. My question to you is, how do we put all these things in Indian patient subset, where every time when I'm talking to my seniors who have been practicing in India for 20, 30, 40 years, there is a sense that Indian patients do behave slightly differently as compared to Caucasians. they may be more sensitive to higher dose of statins. They may be at a higher risk with the same level of LDL in their bloodstream. And there is always this debate about how much statin to give in this patient subset, understanding that the international norms may not be followed in India. I remember this discussion actually came because I was very, very significantly critique of this fixed dose combination where there are dual antiplatelet and 20 milligrams of atorvastatin or 10 milligrams of atorvastatin. There are, I believe, more than 50 fixed dose combinations available where you have got either 10 or 20 of atorvastatin with ecosprin, with aspirin, and with clopidogrel. And I always had this concern that if the patient needs dual antiplatelet therapy for something, then this patient should be on a high dose statin. So a fixed dose combination of 10 and 20 milligram atorvastatin absolutely does not make sense. And one of the thought process that was shared to me was that maybe the Indian patient subset is different. They are far more sensitive to statins. So what may be an 80 milligram for a Caucasian, maybe only 20 milligrams for Indian. Sir, do you share a similar opinion? Do you think that we should be treating Indian patient subset differently in terms of their LDL target and in terms of their statin therapy? Shankar, sir?
This the same question I raised on many platforms. So because our stature, our physique, everything is different from Caucasians. So naturally, I prefer to, only in the initial phases of myocardial infarction where as a pleiotropic effect, I give 80 milligrams of atorvastatin. But immediately after stabilization of the patient, I will switch over to 40 milligrams only with the fear of any myotoxicity in the near future. That is my way of practice, whether it is correct or not, because our patients are very lean, thin, and whether they can tolerate 80 milligrams atorvastatin or not. So that's why I give half the dosage what is prescribed in the Western textbooks. Thank you.
Vijay sir, your opinion on this question? This is something I've struggled for quite some time. What is your take on it?
See, Indian dyslipidemia is different. We have moderately elevated LDL, more triglycerides, low HDL, more high LPA, and more small dense. So our statin requirements may not match this Caucasians. So we can use slightly lower doses also to achieve. Hello? Hello?
Yes, sir. Yes, sir. Please go ahead.
Am I audible?
Sir, your voice is breaking a little bit, but we can comprehend. So you might continue, sir.
So the Indian dyslipidemia is slightly different from other this thing because we got moderately elevated LDL, more triglycerides, low HDL, more of a increased small dense LDL, and more of a high LPA. So our statin requirements may not match this Caucasians. So we can use slightly lower dose of statins because our LDL is not very high.
Perfect, sir. Thank you so much. Yes, sir. Yes, sir. We could hear you.
Hello?
Yeah. Hello, sir. Sir, we could hear you. We could hear your thought.
Okay.
Okay. If anybody else has got any other questions or comments, they can share before I move on to Somaraju sir for his opinion. So, Somaraju sir, you heard the discussion for today, particularly the patient that I brought. Two questions which kind of remained unanswered was rosuvastatin going from 20 to 40, incremental benefit versus incremental risk. And secondly, how Indian subset differs from the Caucasian, and how vigilant we should be when we translate the European or US guidelines to India at its face value. We would like your opinion, but first about this patient and then the discussion that we had. Somaraju sir.
Coming to this patient, what are the risk factors in this patient?
So, sir, this patient's primarily risk factor was poorly controlled diabetes, and other than that family history, there is not anything else.
What is her B12 and homocysteine levels?
Sir, her B12 level at the time of admission was low. That was corrected. It was about 110. That was corrected. I do not remember us checking homocysteine level, but B12 level was low, about 100.
Yeah, thank you. The angiographic information, was it a dominant thrombus or a tight lesion?
Sir, it was a tight lesion. It was in the mid-LAD. She actually had more disease than what I was expecting. Her infarct was mid-LAD.
That is enough.
Yeah.
Having said that, I would, continuing on what you people are talking about, say, on Indian patients versus Western patients, guidelines and clinical trial data. And I would go further to say clinical trial data and guidelines are not directly applicable to each individual patient. In acute myocardial infarction or even chronic coronary artery disease, there are nearly 70 to 80 subsets of each category of patients when you really look at it. Try to apply guidelines, try to apply clinical trial data directly to patients will be a disaster. And then you have to individualize. But most of you are interventional cardiologists here. It is generally stated that no trial proved that elective angioplasty prolongs life, but primary angioplasty prolongs life. But did we stop doing elective angioplasties and stenting? And similar thing applies to what you do with these trials on cholesterol reduction, etc. And you have to individualize. You have to go by individual patients, their risk factors, their extent of disease, the nature of the disease, and social status and economic status, and all those things. Many of you already pointed out most of those things. Unless you individualize, you apply trial data for drugs, but don't apply trial data for interventional cardiology. That's being funny to me. So then individualize and use the clinical trial data to the patients that are applicable. Exceptions are too many in real world of medicine. And I don't agree with the data that you have to bring down everybody's cholesterol to less than 50. Low cholesterol has significant issues. Some of you pointed out the muscle disease and say diabetes, etc. The pre-diabetes is never tested enough. Pre-diabetes also is a risk factor. Then cholesterol is also not a useless substance in the body. It is essential for body mechanisms, particularly nervous tissues, hematopoietic system, etc. And the myelin is essential for neurological function. And there is enough evidence that too low in LDL cholesterol predisposes to cerebral hemorrhages in some subsets of patients. You have to keep all that in mind. And lifestyle modification also should be added to the drug therapy, in which case the dosage of drug you need may be less. And I do not go to the level of reducing cholesterol to 50. Some of you mentioned even 30. I don't believe in it. I don't agree with it. And I'm quite happy if this is less than 100 in most of the patients. And sorry, I have some difference of opinion on these issues. And then using the newest drugs, they are good, they're seemingly useful, but I don't have enough experience, and I'm trying to learn how I can apply it to some of the patients. Thank you.
Sir, one of the questions that I have, I am very skeptical about this. While I do practice it, I am skeptical about this, and that is increasing the dose of rosuvastatin from 20 to 40. What is your take on it? Is it routine in your practice to prescribe 40 milligrams of rosuvastatin? Do you see problems associated with it?
See, one of the very few of my patients will be on 40 milligrams. Most of them are 20 or less. And intolerance to statins is common. And also drug compliance is a serious issue long term. One of the commonest reasons why cholesterol fails to, say, cholesterol doesn't reduce in some of the patients is because of drug compliance, they don't tell you the truth.
And sir, one last question. Now, when we talk about secondary prevention of ASCVD, we give higher dose of antiplatelet, sometimes antithrombotic early in the phase because we think the first few months are the most vulnerable phase. Does the same thing hold true for lipid management, where we should be aggressive in the first few months and then we can be less aggressive as we speak later on? Is that a strategy that is scientifically validated?
As we already discussed, I think it's true for many patients, but then you have to individualize the nature of the disease, extent of the disease, what intervention was done, not done, etc.
Thank you so much, sir, for your opinion. I typically we don't put our huddle for a particular drug. In this case, in today's discussion, while we did talk about lipid management, we focused a little bit more on one particular drug, and my rationale of doing so was because it's a drug which has been tested quite a lot. As Praneeth mentioned, we so far do not have cardiovascular outcome data. That is work in progress. But the fact that this drug works on the same line as statins, everybody is of this opinion that the data should come out positive. And of course, you know how the data works, particularly when one industry is driving it. You can pretty much assume the data is going to come out positive unless the drug is really horrible. And also the fact that Shankar sir mentioned, because it is not metabolized in muscle, it for the drug to cause objective damage to muscles is probably not possible. Patients may still have symptomatic muscle symptom that is same as in statin, where a lot of the symptoms are somatic in nature rather than organic in nature. We do have to understand that most of the cardiovascular drugs which affect our lipid metabolism or which affect our hemostatic mechanism, they do increase uric acid level. In fact, a lot of the drugs that we use in our day-to-day practice for cardiovascular disease, hyperuricemia is a side effect of that. And that is the reason why there was this whole discussion that uric acid may not be the target of therapy for cardiovascular risk reduction, because increased uric acid in patients who have got cardiovascular disease may not necessarily be because of organic cause. It may be just because of accumulated side effects of the drugs which have been prescribed, for example, beta blockers, statins, or whatnot. All these drugs, they tend to increase uric acid. So it is also possible that the increase in uric acid that we are seeing with bempedoic acid may just be a temporary thing that we saw with all other drugs. It is an oral drug, it is an once a day drug. All the issues related to tendon rupture and all of this that has been seen, the signal has been there. This is something we have to watch for. In most of the cases, these patients were on a concomitant drug like steroid or fluoroquinolones or extremes of age. So that is also something that we have to watch for as we are going forward. This is something Shankar sir mentioned already. So,
Anoop,
yes, sir.
can I?
Yes, sir.
Actually, it's a very useful topic and it's very informative and useful. I'm not questioning the validity of discussing the drug, but I also just want to mention uric acid. There is increasing evidence uric acid contributing to vascular disease more and more, whether the drug-induced increase in uric acid, whether it has any adverse effects on vascular disease, I am not sure, but we need to look at it. Thank you.
Yes, sir. I think this point has been confusing to a lot of us, or a lot of scientific committee, I should say, where the whole question of the effect of organically, like those patients who are truly hyperuricemic versus those patients who became hyperuricemic because of all the drugs and all the treatment effects that we have been doing. And at times it becomes very difficult. There is signal that patients who are hyperuricemic to begin with, that extra uric acid does affect certain systems of our body. Kidneys are at the forefront of it. Nephrologists have a very strong opinion that hyperuricemia could be one of the cause of chronic kidney disease, and vascular disease is certainly one of the primary thoughts behind it. It is just that whenever we see high uric acid in those patients who have established cardiovascular disease, it is very difficult as a clinician for us to differentiate whether this is chicken or egg scenario, whether this is a cumulative effect of all the therapies that we have been doing versus an organic hyperuricemia. Having said that, back in the day, we were treating these patients with allopurinol and whatnot, which were not very safe drug, particularly with renal clearance. Nowadays, most of these patients are being treated with febuxostat, which seems to be a relatively bland drug when it comes to side effect profile. So a lot of these patients who do come to me with febuxostat, I tend to not stop it. I tend to continue it, although I don't know the clinical implication of it. I typically stop that drug when there is polypharmacy involved or where the patient actively seeks reduction in pill burden. In those cases, if they don't have a history of gout or established uric acid pathology, I tend to actively stop those drugs. So anyway, that was my discussion on this topic. I believe once the drug hits the market, once all of us gain some experience, maybe in the next 5-6 months or so, we can revisit this thought. Just like SGLT2 inhibitor, where now all of us have some experience of using this drug versus 2 years ago, where very few of us were prescribing this. So with this, I would like to close the discussion unless somebody has anything active to discuss. Praneeth, your comments on today's discussion.
Yes, Anoop. Lipid lowering therapy, I think, is cornerstone for every cardiologist and equally a physician because it is an important risk factor for all the ACVD events. With the growing knowledge and increase in availability of various therapies targeting at various levels of the lipid metabolism, I think we should be aware of all these various drugs, how they act and when to choose or how to prescribe and what to do. And because now this new molecule is hitting the market or is already hit the market, I think this is a refresher to kind of know about this molecule and gives us a confidence to know how to prescribe. I think starting from statins to other alternatives on what are all the available drugs that we have today, being statins, STMI, PCSK9, and the new kid in the block, Bempedoic acid. I think various aspects have been well covered. And I hope that with this session, we will be a bit more confident in prescribing Bempedoic acid for those deserving patients. Thank you, Anoop.
Thank you, Praneeth. Thank you all of you for attending today's session. We will be back next Wednesday with a new topic. Till that time, good night. We'll see you next week. Take care.